So basically, patients who relapse with ovarian cancer, they have a very bad prognosis because they receive chemotherapy, they have a pause, they receive chemotherapy, they relapse again and again and again, and with all that toxicity and eventually die. So the idea is that we really need some maintenance therapy which can keep them longer time away from the toxicity of chemotherapy, and probably also will have them to live longer, and that was the reason we needed this maintenance therapy. PARP inhibitors is a beautiful class of drugs which affect typically on the cancer cells who have some sort of mutations which make their DNA repair deficient. And then PARP inhibitor can work on that, and in that way you go and affect the cancer cells and do not affect that much the normal cells. So we had, this is a randomized trial where patients who had relapsed, they received their standard of care chemotherapy. Once they had finished their chemotherapy, they entered our trial where patients were, we did the BRCA testing, and according to BRCA testing, the patients were divided into two cohorts. And 553 patients entered the study. In gBRCA mu 203, in non-gBRCA the rest of the population 350. And these patients received 2-to-1 randomization Niraparib or a placebo once daily as an oral therapy until progression. And the most fascinating thing is that we have about 43% of the patients at the time of data cutoff still on active treatment, have not progressed. So in the non-gBRCA cohort, we also performed HRE test, and that HRE test was to see if HRE positive population is the responders and HRE negative populations are non-responders. Well, there is a difference, but that difference is small because hazard ratio shifts from 0.38 in HRE positive disease to 0.58 in HRE negative disease. Well, the question we as a clinician has, HRE negative disease with a hazard ratio of 0.58 with a 42% of risk reduction and 1/5 of the patient's own treatment without relapse at the 18 months of data cutoff is clinically so meaningful that we cannot say to these patients that we are not going to give treatment. So therefore, HRE test cannot be used to split the patients between responders and non-responders. And our clinical conclusion is that the drug is so effective also in HRE negative that all patients should receive it.